All right, everyone, welcome. Today we are breaking down one of the most common and, frankly, critical decisions you're going to face in neurology: how to start treatment for epilepsy. You know, getting this right from the start, can literally change a patient's entire life. So let's get into it.
Okay, let's put you right in the hot seat. Imagine this. You're in the clinic, maybe the ER, and a patient comes in who's just had their very first seizure. They are terrified. Their family is an absolute wreck, and they are all looking at you for answers. The clock is ticking, and this first huge decision, it's all on you.
So, here's our game plan. We're going to start with that big first decision: to treat or not to treat. Then we'll get into matching the right drug to the right seizure. After that, we'll talk about tailoring the treatment to the person, not just the disease, navigating the risks, and finally, putting it all together in what I call the art of balancing.
All right, first up, the first seizure decision. This is a big deal. I mean, you're potentially starting someone on a medication they might take for the rest of their life after one single event. So you can't just wing it. You need a system.
First things first, we have got to get our words right. A seizure is not the same as epilepsy. Think of it like this. A seizure is like a single thunderstorm. It's a one-time electrical storm in the brain. Epilepsy, on the other hand, is like the climate. It's the underlying condition, the enduring predisposition to have those storms again and again. So remember, one seizure does not equal epilepsy.
So how do we make that call? Well, it's not a gut feeling. We use a clinical roadmap, an algorithm to figure it out. And it all boils down to one central question. What is the risk that this is going to happen again? Our job is to become risk calculators.
And these are the big red flags we're looking for. If your patient has any of these, an abnormal EEG, a known brain injury, like an old stroke, something off on their neuro exam, or if the seizure happened while they were asleep, their chance of having another one just shot way up. In fact, it's high enough that we can confidently say they have probable epilepsy, and it is time to start treatment.
Okay, so we've decided to treat. Now what? Now we have to pick the right tool for the job. And in epilepsy, that starts with correctly identifying the seizure type. I can't stress this enough. If you get this part wrong, your treatment could be useless or, even worse, it could actually make the seizures worse.
This is the fundamental fork in the road. You've got focal seizures and you've got generalized seizures. Focal seizures start in one specific spot, like a small fire starting in one room of a house. Generalized seizures, though, they involve the whole brain, both sides right from the get-go. The whole house is on fire at once. And this one distinction, it changes everything.
And because we have those two types of seizures, we have two types of drugs. Think of it like a toolbox. Broad-spectrum drugs are like your Swiss Army knife. They work pretty well for both focal and generalized seizures. They're versatile. Narrow-spectrum drugs are more like a specialized wrench. They're designed for one specific job, usually focal seizures. So let's look at the actual players. For broad spectrum, you've got the modern workhorses like levetiracetam and lamotrigine. For focal seizures, you might use something like carbamazepine. But look at this special call out here for absent seizures. For those brief, staring spell seizures, there is one king, and its name is ethosuximide. It is the absolute gold standard for that one specific job. Do not forget that one. All right, so we've matched the drug spectrum to the seizure type. We're done, right? Not even close. This is not cookbook medicine. Now comes the real art, tailoring our choice to the unique human beings sitting right in front of us.
You have to see the whole person, not just their EEG. So you ask yourself, how old are they? What's their deal with family planning? What other health problems are they dealing with, like kidney or liver issues? And, what might be the most important question of all, what other pills are they already taking?
Take older adults, for instance. For them, a minor side effect can be a catastrophe. A little bit of dizziness for a 25-year-old is an annoyance. For an 85-year-old, that's a fall, a broken hip, and a total loss of independence. It's a game changer. That's why we lean toward the cleaner drugs like lamotrigine or levetiracetam, which cause less of that and don't mess with their other medications.
Okay, everybody, listen up, because this is a non-negotiable, never-ever rule in modern epilepsy care. For any female of childbearing potential, valproate is essentially off the table. The risk of causing serious birth defects is just way too high. This is a massive patient safety issue. On top of that, you have to counsel them about contraception, and you must prescribe folate. No exceptions.
And this is just, well, it's just good plumbing. You have to know how the body gets rid of the drug you're prescribing. If your patient's kidneys aren't working right, you can't give them a full dose of a drug that's cleared by the kidneys. It'll build up to toxic levels.
The exact same logic applies to the liver. It seems basic, but it's a mistake that's easy to make if you're not paying attention.
So, we've picked our drug, but these things aren't Skittles, they're powerful medications, and we have to be totally honest with our patients about the risks, from the really common stuff to the super rare but incredibly serious dangers.
You need to set expectations. You'll tell your patient, look, when you first start this, you're probably going to feel a little drowsy, maybe a bit dizzy. With a drug like levetiracetam, you might even feel kind of irritable. But the key to managing this, and you will say this over and over, is our mantra. Start low and go slow. We give the brain and body time to get used to it.
But then, there are the other side effects, the ones that are not common at all, but when they happen, they are absolute medical emergencies. These are the ones you can't afford to miss.
I want you to burn these acronyms into your memory. SJS, TEN, and DRESS. These are catastrophic, body-wide allergic reactions. And here's the take-home message. If a patient you recently started on a drug like lamotrigine or carbamazepine calls you with a new rash and a fever, that is a medical emergency until proven otherwise. You need to get them seen. Immediately.
And finally, we have to talk about how these drugs interact with other meds. Some of the older ones, like carbamazepine, are what we call enzyme inducers. They basically put the liver's drug disposal system into hyperdrive. The result? Other vital medications get chewed up and spit out before they can work. We're talking about birth control failing, blood thinners becoming useless. It's a huge, huge problem.
Okay, let's pull all these threads together. After weighing all of this, what are we actually trying to do? What does a win look like in epilepsy treatment?
It's a three-way balancing act. Of course, goal number one is to stop the seizures. We want to maximize efficacy, but we can't do that at the cost of crippling side effects, so we have to minimize those tolerability issues. And this all has to happen within the context of the actual person's life, their job, their goals, their other health problems.
And that brings us to the single most important point of this entire talk. If you remember one thing, make it this. You are not just treating seizures. You are treating a person. Achieving seizure freedom but leaving the patient with a miserable quality of life is not a victory. The ultimate measure of your success is their quality of life. That's how you'll know you got it right.